Okay, welcome to EHDI 101 for our EHDI hospital contacts. I am going to get started with our presentation here. And the target audience for this presentation is hospital staff that have administrative oversight of newborn hearing screening in New Jersey hospitals. This presentation is not designed as an orientation for screeners. For that, we recommend the training curriculum that's produced by the National Centers for Hearing Assessment and Management, and that can be found on the website infanthearing.org. Instead, this program will focus primarily on the New Jersey regulations regarding newborn hearing screening that must be followed by New Jersey hospitals. As you watch this presentation, I would encourage you to jot down any questions you have that are not answered during the program and send them to the Department of Health staff when the presentation is over. We will respond to your questions and also create, maintain, and post a frequently asked question document to accompany this presentation. EHDI stands for the Early Hearing Detection and Intervention Program. Part 1 today is going to focus on the requirements for screening and policy and procedure requirements that are in the state regulations. Part 2 will focus on the second half of the EHDI regulations, specifically that deal with follow-up. And Part 3 will discuss the quarterly reports that are produced and some of the QA and efforts of the New Jersey Department of Health staff. To introduce ourselves to you, the New Jersey EHDI team consists of several people. You also have their contact information, how to reach us by voice or TTY or fax or email, and our website, which I'll talk about a little bit more as well in this presentation. Oversight of the EHDI team is by Leslie Barasachka. She's the program manager, and her responsibilities are the Early Identification and Monitoring Program, which includes not just EHDI, but also the birth defect and autism registries. I am Kathy Avini, and my title is Research Scientist. I'm primarily responsible for the data management aspects, maintaining the database, doing reports, and also administrative oversight, grants management for our program. I've just got our staff up here in alphabetical order. So in addition to myself, there's Linda Biondo, who is a title is Public Health Consultant Nursing. Her primary duty is to be the liaison with the hospital, so it's probably Linda that you'll be speaking with most with respect to any questions you have about your policies and individual procedures and screening techniques that are going on at the hospital level. Linda's also our liaison to the pediatrician community, does outreach to that group of healthcare providers. Tracy Justice is the clerk in our program, so if you need brochures, that's the person you'll be speaking with most likely, and she provides the clerical support for our program. Nancy Schneider is our audiologist with also the state title of Research Scientist. She provides the technical expertise for this program and is the liaison to the audiology community. We certainly welcome you to reach out to any of us at any point in time. I provided this contact information and our specific email addresses so that if you do have a specific, say, question about a piece of equipment, that might be best directed to Nancy. If it's about your policy, that would best be directed to me. If it's about to Linda. If it's about your statistics, that would be best directed to me. But certainly we can all help you at any time. I did want to briefly start with why we do newborn hearing screening in New Jersey and why it's done nationally before I get into our individual regulations. And hearing loss is more common than many other conditions that we treat or that we screen for in the newborn hearing, in the newborn period. Hearing loss is estimated to occur in about 3 of every 1,000 newborns. This chart shows you how that compares to some other neonatal conditions. You can see that hearing loss is more common than some other birth defects or chromosomal anomalies. And those shown here are usually very visible and noticeable at birth, while hearing loss can be largely invisible. You can see that hearing loss is also more common than other conditions that are part of the blood spot screening panel, including things like sickle cell anemia and PKU. The other reason that we do newborn hearing screening, and the advantage is that besides finding a relatively common condition, is the early identification and treatment can make a big difference for these children. This slide shows the results of a study that was done looking at language development in children with hearing loss. That was done comparing children who were diagnosed earlier and those that were diagnosed later. You can see that the pink bars show that for children identified before 6 months of age, by the time they were 3 years old, their language age was 30 months. So just a little bit behind schedule. That's compared to children who were identified after 6 months. The blue bars represent those children identified later, and you can see that by 3 years old, their language age was only that of an average 20-month-old child. So they were much farther behind schedule in their language acquisition than children who were identified and began intervention earlier. As soon as babies are born, they aren't talking and forming words, but they are listening, and they are learning to associate words with things. Like when they hear, "Mommy loves you," they usually see that pretty woman's face. If they don't hear those words, they still recognize their mother's face and recognize that face as being who's frequently taking care of them, but they're missing the chance to know that we use words to mean certain things. Interventions like providing amplification options or improving the listening environment can be started very early. Hearing aids can be fitted on babies as young as 4 weeks old. So because of those benefits, we have some national goals that we have adopted in New Jersey as well for newborn hearing screening. We call them 136 because we want to screen all newborns by 1 month of age. We want diagnostic testing of children who do not pass the hearing screening to be completed by 3 months of age. And we want children with a diagnosed hearing loss to be enrolled in a culturally competent and family-centered early intervention program by 6 months of age. I want to highlight a few of the elements of New Jersey's hearing law. New Jersey does have a law that mandates universal newborn hearing screening that was passed in January of 2002. It mandates that hospitals screen infants for hearing loss either by discharge or by 30 days of age. It also mandates the establishment of a central registry of newborns identified as having or being at risk for developing a hearing loss. So that stipulation in the law gives us, at the Department of Health EHDI program, the authority to collect screening and outpatient follow-up information so that we can track those babies appropriately. The law does require Medicaid and also insurers that are regulated by the state to cover the cost of these hearing evaluations. It's important to keep in mind that some insurance plans are not bound by state law. If they are written out of state, if they are self-administered or self-funded plans, they're not held to state law because they're held to federal law instead. So the law in that case doesn't specifically apply. So having insurance doesn't necessarily guarantee payment for hearing screening in all circumstances, but that was the intent of the legislature when they passed the law that parents not be burdened by the cost of the newborn hearing screening. The law also mandates that hospitals shall have guidelines for the provision of follow-up services, and we're going to talk more about that in this presentation and in our EHDI for Hospital Coordinators Part 2 presentation as well. The law is available on our EHDI website, www.nja.gov/health/FHS, because we're in the Division of Family Health Services /EHDI, and you can get a lot of information about our program on that website. New Jersey Administrative Code is often referred to as the rules or the regulations or the regs. And it's the legal language that more specifically details how the Department of Health expects to implement the law that I just talked about. The rules are what gives the Department of Health the authority to require hospitals to do certain things with respect to their newborn hearing screening. Rules are in effect for 7 years after adoption. So the rules presented here became effective in June of 2011, so will continue to be in effect until June of 2018. And at that point in time, our program may choose to readopt them as they are, or more likely revise them and tweak them a little bit. Rule revisions always include a public comment period as part of that process. So if there are things that you don't like that you hear today that you say, well, gee, I don't like the way the state is making us implement this, and I think it would be better done another way, keep those in mind, and certainly we'd like to hear that back from you so that when we do revise and readopt our rules that we can consider your comments as well. We also wrote the most recent administrative rules trying to comply with the Joint Committee on Infant Hearing Position Statement. That organization more aptly is referred to as JCIH. And the JCIH is a committee composed of many agencies that are interested in newborn hearing screening, including the American Academy of Pediatrics and the American Academy of Audiology. We try to have our rules be consistent with the recommendations of the current JCIH position statement. And as I'll talk about later, we have specific points where we refer and defer to the JCIH position statement specifically for monitoring risk factor babies. What I'm going to be doing for the rest of this presentation really is going through the rules in order, step by step, to make it clear to our primary hospital EHDI contacts what your regulatory requirements are with respect to screening. So you can see that the next bullet on my slide is a citation of the rules and it's New Jersey Administrative Code, Title 8, Chapter 19, and then Section 1.2 states that upon or prior to the admission of a newborn, the hospital must provide parents with literature provided by the department. I skipped over Section 1.1 because that's just definitions and thought that would be extremely boring to you. But so 1.2 says that you need to provide the parents with literature, and we did produce a document for you to provide, a brochure for you to be providing to parents. It's titled, Can Your Baby Hear? It should be given to all parents, and it should be given even if you have your own document that you've developed that talks about newborn hearing screening. You should also give out this one because we're trying to give a consistent message to parents. These brochures were developed by the National Center for Hearing Assessment and Management, more shortly known as NJAC, which is a national organization that has as a focus early identification of hearing loss and serves in many ways as a technical support to the various different state EHDI programs. So they were pilot tested for reading level and cultural competency, and then we just added the New Jersey specific contact information to these brochures. In addition to Can Your Baby Hear, we have another brochure called Your Baby Needs Another Hearing Test, also developed by NJAC. And this should be given to families with a baby that have a refer or non-passing result on their inpatient hearing screening. You may also want to consider giving this out to parents of families that have a child that has a risk indicator for late onset hearing loss, because that baby will also need eventually additional follow-up testing. And again, it's designed to be sort of parent-friendly and relatively low literacy levels, and we have that available for you. Both of our EHDI brochures, both Can Your Baby Hear and Your Baby Needs Another Test, are available in English and also Arabic, Korean, Polish, Portuguese, and Spanish. When we did the translations, looked at the languages that were most commonly spoken by women of childbearing age or women actually delivering infants in New Jersey. So that's how we selected those languages. To get those brochures, you can just contact us. You can send us an email or give our program a call, and we will happily send out brochures to you. We can put you on a mailing list so that we send you a certain number of brochures every month or every 6 months, however you would prefer to receive them. We also keep copies of the brochure as PDF files on our EHDI website, so that if you say don't typically have Korean families in your patient population, but one day you do, you can hop onto the EHDI website and print out just one copy of the Korean version so that you can provide that to the parent in your hospital. Moving on to Section 1.3 of our rules. That says that each newborn shall receive hearing screening by the 28th day of life. If they're medically unstable at 28 days, you can complete the hearing screening as soon as the infant is medically cleared. That sounds, I'm sure, very obvious to you, but we wanted to make sure that we spelled that out in our rules so that you weren't held accountable for screening by 28 days if the baby wasn't in fact stable for that testing to be done. And you can see how we're doing in New Jersey with newborn hearing screening. This graph shows the percentage of babies that were screened either by discharge or by 30 days of age. And it's clear that all of our New Jersey hospitals are doing an awesome job of meeting the screening regulations. So we give all of you a hand, here's my hand, for doing such a great job at getting babies screened. A few hospitals, you can see, were doing screening even before the legislation was passed. And when it was passed in 2002, all hospitals came on board. And so currently hospitals are managing to get 99.9% of babies screened prior to hospital discharge. At Section 1.3, Item B in our rules, we stipulate that basically that facilities are allowed to select whatever type of screening test that they prefer, except that babies with a NICU stay of greater than 5 days must have an ABR. So hospitals have a choice of screening methods. The current screening methods in use are either otoacoustic emission screening or auditory brainstem response screening. And this recommendation about NICU babies is made to be in compliance with the JCIH position statement. The reason for this recommendation is that the ABR is the only screening method that can detect a specific type of hearing loss called auditory neuropathy or auditory dyssynchrony, and that type of hearing loss is found more commonly in NICU babies. Now, the definition of NICU, in the JCIH position statement, they just refer to NICU. In New Jersey, we have hospital licensure regulations around our nurseries, and we have bassinets identified as both intensive and bassinets identified as intermediate. So in reviewing the JCIH position statement in comparison with our regulations, we've determined that the NICU definition is really consistent with our definition of intensive bassinets. So if your hospital is only licensed with an intermediate nursery and not an intensive nursery, you are not required to perform ABR screening on those babies. The other thing to think about is if you're at a hospital that does have an intensive nursery and also has an intermediate or step-down nursery, and you have babies going back and forth between those nurseries sometimes, it's important to be able to appropriately track and count how many days the baby was in the intensive nursery in order to see if this criteria applies to those babies. The other point I like to make when we talk about this is certainly we just know from a very high level and a statistical level that you have babies in your hospital and that you're licensed as an intermediate or you're licensed as an intensive. We don't know the condition of individual babies, and that's something that you do know. And I know that hospitals do sometimes have babies that are in an intermediate nursery and in theory should probably be transferred to an intensive nursery based on their weight or their ventilator status, but sometimes are managed and are monitored in an intermediate level nursery. So just to think and to be aware of the fact that if you had a baby that probably should have been transferred to an intensive nursery but wasn't, it probably should be receiving an ABR screening. So you also need to be careful about documentation if you have both an intermediate and intensive nursery when you document the number of days a baby is staying in those nurseries in our state's electronic birth certificate system, because that's what we use to identify if you are complying with this mandate to do ABR in NICU babies with a greater than 5-day stay. This shows you for 2012 births in New Jersey that were screened, what screening method was used. You can see that it's a little bit more common in New Jersey for ABR to be completed than for OAE. So we have 56.6% of babies with an ABR, 40% with an OAE, and the remainder got both test types done in the hospital. At our regulations at 1.3D, we indicate that each birthing facility must file a plan with our program, the EHDI program, detailing how the facility is going to implement newborn hearing screening in accordance with this chapter. We do say that it has to be submitted by July 31st of each year. Now, if your protocol hasn't changed in the last year, what we do every July is just ask that you verify for us that it's the same. You don't necessarily need to resubmit it, but we do need to know that it's been reviewed and that that's your current policy and procedure. In addition, in this section of our reg, there are many, many things that we require you to spell out in your plan. And some of these things I'm going to be talking about in more detail as we progress through this presentation. We do want to know the method. Are you using ABR or OAE? We also do want to know the specific make and model of the hearing screening equipment that you're using. Are you using a biologic or a Natus product? Are you using, if you're using the Natus, are you using the Algo 3 or are you using the Algo 5? The reason we want that specific information, there are a couple reasons. One is that we have had instances in the past where hearing screening equipment has been recalled, and we've been aware of that, and so then we've been able to follow up with the hospitals using that equipment to make sure that they have replaced or repaired the relevant equipment. We also want to know in your policy the time frame after birth that you're planning on doing screening. Your equipment manufacturer might provide a specific time frame to wait, such as after 12 hours. You may have other timing criteria. You may prefer to do it during the night shift because it's quieter in the building. Whatever criteria you have like that, these things should be stated in your policy. We also want you to include the qualifications and training received by personnel designated to perform the screening. I'm going to talk a little bit more about that later. And the establishment of quality assurance protocols to evaluate the effectiveness of your program. Quality assurance processes may include such things as reviewing your refer rates by screener or looking at annual trends in refer rates and in follow-up rates. You could also, as a quality assurance effort, do a chart audit of a few cases every month so that you can verify that the results were recorded correctly and reported to the state via the birth certificate system correctly. You can also consider a quality assurance effort such as doing a random survey of parents to ask them if their screener provided them with information about the screening results in a way that was satisfactory and understandable. Any of those would make excellent quality assurance efforts, and we do want to be sure that you're always trying to improve, consistently improve and monitor the success of your newborn hearing screening program. We'd also like to know the month that's designated for annual performance evaluation of the equipment, what specific type of maintenance or equipment checks are needed. Varies based on the type and the manufacturer and the piece of equipment. So check your equipment manual to see how yours needs to be maintained. Does it need to be done by the vendor or can it be done in-house? You should be verifying that the equipment is operating correctly at least once a year, and you should state that in the policy. You also need to include the name of the licensed audiologist or physician that's designated pursuant to Section 1.5, so we'll talk about that more when we get to Section 1.5 of the rules. Some other things that need to be in your policy are the mechanism to ensure the screening of an infant that gets transferred to another facility. We're also going to talk about transfers some more and who's responsible, but we want that communication process and documentation process for transfers spelled out in your policy. We're going to cover item 9 in great depth in our EHDI for Hospital Coordinators Part 2 presentation, which we're going to record as a separate webinar. But your hospital policy should spell out what sort of efforts you are going to be taking in ensuring parents get needed follow-up. You also need to spell out at what point and under what conditions you will report a child as being lost to follow-up. Again, we'll talk about that more in Part 2. And you want to document the educational and counseling services that you plan to provide to parents. If you're just giving out your "can your baby here" and the baby needs another test brochures, you just want to write that down in your policy so we know what education is being given. You also want to make note in your policy of who is responsible, the guidelines for entering the screening results and the risk indicators into the EBC. So specifically, who is responsible for entering the results in the electronic birth record, and if that's a different person from the screener, how do you make sure that the results get passed from the screener to the data entry staff correctly and timely? The next item that needs to be mentioned in your policy is the protocol to ensure confidentiality of the information, and also ototoxic drug screening procedures, which we're going to talk about in depth again in Part 2. Now, so far today I've mostly been quoting the rules exactly or paraphrasing them. Also today I'm going to make a few recommendations or suggestions of things that we think are best practices. I'm going to do my best to be clear about what things in this presentation are required, because that's the main focus of this presentation, and also to spell out for you what things are merely recommended. Mostly, if you see the administrative code citation, like here where you see the 819.1.3e, if you see those little numbers in front of one of the bullets or text items on the screen, that's requirements because it's actually in the administrative code or the rules. Anything else without that little citation in front of it, so if you just see bullets on the screen like here, these are things that we feel are important elements of the hospital's newborn hearing screening program, but not necessarily required. We did create this list because we believe these are really important elements, and we also know that your policy really sets your hospital's standard of care. So it's important that it be as good and as effective as possible, and that you be following it as well. I do want to let you know that if you have information that can change readily, so you make and model of equipment, the person in charge of the program, and you don't want to have to put your whole policy through your internal review processes, those specific elements that are subject to change, you can send us as a separate addendum, and they don't have to be part of your core policy. Additionally, we do have the requirement that your policy must include information about keeping the information confidential. We know that most hospitals have a hospital-wide confidentiality policy or procedure that they follow, so you don't have to repeat that whole thing in your EHDI protocol. You can merely make reference to your hospital's confidentiality policy. The EHDI program does have a checklist that we can give to you and that we frequently will give out in July of every year to help you do the self-assessment of your policy so that you can run through all of those many items that I just spelled out for you and make sure that your policy complies with those. The other thing that I would hope that we don't have to say, but I will point out, is that you need to be sure that you're actually following your hospital policy. If you say that you're going to train your screeners by giving them 2-hour time with a preceptor, and then they're going to be observed for the first 10 screens that they do, and you're going to make them take a written test, then you actually need to be sure you're doing those things. Whatever it is you're training, it is spelled out in your policy, the QA that's spelled out in your policy, all of that, a lot of that is up to you, and we allow some discretion in what works for you, but you do want to be sure that you're following it. It is your sort of legal documentation that's setting your standard of care. So this next section, or a few elements, were put in the regs to mirror the recommendations that are in the current JCIH position statement. And they talk about rescreening exams, and so they do apply if you do a repeat screening in the hospital. If the baby doesn't pass their first screening and before discharge, you get another screening done. And that is that if you need to rescreen both ears, even if the prior refer was only on one ear. If the baby referred on an ABR, the follow-up rescreen also needs to be done with an ABR. And if the baby refers on an OAE, follow-up can be done with either OAE or ADR. One frequent question that we get about item G, the rescreening both ears, is what counts as a rescreening. If you start a screening and the baby passes on one ear, and then you move over to the other side and the baby refers, can you just hit the restart or reset or button, whatever button on the machine starts it over again, and rescreen just that second ear and not have to go back to the first ear? And our guidance on that is if you haven't disconnected the equipment from the baby and you haven't walked away from that baby, so you're clearly just restarting on the same ear with the same leads, then this is counted as one screening session, and it's okay to just repeat the one ear. As soon as you disconnect equipment, switch leads, walk away from the baby, retest the baby at another time, and there's a possibility that maybe your leads were crossed and the one you thought was right was really left and vice versa. In that instance, you should always rescreen both ears when you attempt the rescreening. If a baby passes the right ear and refers the left, and then the next day you test again and now they refer on the right ear and pass the left, that is the flip of the first result, you should always be sure to refer the family for additional follow-up. We'd like both ears to pass at the same approximate time or the same screening session. We also want to remind you, and this is a recommendation, that you not make numerous inpatient screening attempts. We don't provide a specific recommendation on how many times you should attempt a rescreening, for one reason, just because if we have some of you may have babies that are in the hospital and in the NICU and may be there for several months, and you may have multiple opportunities to rescreen them days or even weeks apart. So a baby that has a very long stay, conducting 4 or 5 rescreenings may be appropriate because it may be several weeks apart each time. But what we don't want you to do is be doing 5 or 6 screenings on a baby that's just in the hospital for a couple of days. In general, we would say that we don't want you to do more than 2 screenings unless there's a lag time of a day or 2 between the screening attempts. Thus, all this said, it is often beneficial if you have the opportunity after the first screening attempt to do a rescreening prior to discharge. So maybe if you do the first screening on the first day of life and you get a chance to screen baby again on the second day of life before they go home, hospitals typically find that a very useful thing to do, because as soon as families walk out of your door and they'd have to come back either to your facility or to another facility for outpatient follow-up, we run the risk that they fail to show up for that additional follow-up. And while they're still a captive population, if you do get a chance to conduct a rescreening while they're still with you, you may be able to get a pass result on that second screening and have that child not need additional follow-up. Another thing to be mindful of is that if the screening is taking a very long time to run, it's probably better to stop the testing and try again later. How long a screen takes varies by equipment, so you should become familiar with the norms for your equipment. In our next section of our administrative rules, we say that any baby that is readmitted to your hospital for hyperbilirubinemia at levels that require an exchange transfusion or for culture-positive sepsis should have a rescreen conducted when they return to the hospital. Again, these criteria were put in to comply with the Joint Committee on Infant Hearing position statement. If you admit a baby for hyperbili but no exchange transfusion was necessary, or the baby's readmitted for a condition not listed here, you are certainly allowed to rescreen the baby. You're just not required. Our regs set the minimum standard, and you can always choose to exceed them. And the next section says that if you refer babies For follow-up care, you need to be sure to refer them to individuals licensed and trained to do rescreening or audiologic evaluation. We're going to talk about that a little bit more when we talk about personnel. But one thing that you need to be aware of that's sort of hidden sometimes in our regs is that we do, again, to comply with the Joint Committee on Infant Hearing Position Statement, say that babies that have a NICU stay of more than 5 days should always have that outpatient follow-up with an audiologist, as opposed to just someone who is able to do a rescreening exam. They may receive rescreening only with that audiologist, but it's good to have the babies with that risk factor receive the full evaluation, the full history of an audiologist. I have several slides now on transfers because we have a lot of situations that involve transfers, and the rules vary on the various situations and try to spell out all the possible situations. The responsibility for the screening of transfers is based primarily on the New Jersey Hospital licensure guidelines in terms of, and that's why I'm referring to lower levels and higher levels. So I'm referring to the licensure guidelines around nurseries and the guidelines which describe a nursery as a basic, an intermediate, or an intensive. When we have a baby go from a lower level, so a basic or an intermediate hospital, to an intensive level hospital, so a lower level to a higher level, the higher level facility is held accountable for the screening. Again, in most cases and in most transfers, we have premature babies born in a hospital that's not equipped to deal with them. They're transferred right away. You wouldn't have had the opportunity to do the screening prior to the transfer anyway. And then usually they stay at that higher level facility until they go home. And again, it's easy and it makes sense for that higher level facility to screen the baby. We do, though, sometimes have babies that go either as a result of a maternal transport or a newborn transport. Maybe they go from a lower level facility to a higher level. And then instead of being discharged home, they go back to a lower level facility as sort of a feeder grower. Even in those instances, we hold the higher level hospital accountable for the screening. Basically, our feeling is if the baby is stable enough to be put in an ambulance and taking a trip to another hospital, and it's a lower level hospital, they should be stable enough for you to be able to attempt a screening on that baby. There are some exceptions to that, we know. So if in any instance you are sending the baby from a higher level facility to a lower level facility and you're not able to conduct the screening, you should be sure you notify the receiving hospital that the baby hasn't screened, and also that the receiving hospital, if and when they do screen the baby, needs to be sure to report the results to the Department of Health. But the higher level facility remains accountable for that baby in terms of their statistics and who we expect to do any additional follow-up on that baby. Another unusual situation, we've talked about the regs, the rules say that the lower level to the higher level, but we do have babies that are sometimes transferred between equal level facilities according to their perinatal designation. And again, this mostly is just between regional perinatal, from one regional perinatal center to another regional perinatal center, maybe because the baby can have a surgical procedure done at one hospital that can't be done at the first hospital. And babies may go back and forth between these facilities. So in those instances where there's a transfer between equal level facilities, it is the hospital that sends the baby home ultimately that we make accountable for conducting the newborn hearing screening exam. Another transfer situation is where a baby goes to an in-state hospital, but it's not a birthing hospital. Children's Specialized Hospital is the most frequent example. We also have Weissman Children's Hospital that gets some babies. And those hospitals may be able to do follow-up testing on a baby and do audiologic testing on a baby, but again, we would think and hope that if a baby's stable enough to make that transfer to long-term care, that they're stable enough to have a screening attempted. So we would ask you to try and screen the baby before transfer. And again, that if you're not able, you do have an obligation, and this should be spelled out in your regs, in your policy, how you're going to do this, that you should notify the receiving hospital of their need to screen. And again, your hospital is held accountable for the outcomes and the follow-up of those babies. And our final transfer situation that we want to talk about is out-of-state transfers. So if a baby goes to New York, Pennsylvania, any other state, Delaware, in this case, your hospital is not held accountable for the child or any follow-up. According to our regs. We do say in our regs in these instances that you need to include a copy of our newborn hearing follow-up report to go along with the baby to the receiving hospital. It's basically our attempt when we wrote the regs to remind or prompt the receiving hospital that they need to try and send the results to us at the EHDI program. And this is what that form looks like, has demographic information as well as a place to put the results. Copies of this form are available from our program. You can call, we can download copies on the internet as well. And also on transfers, we do have babies sometimes that are screened and pass in one facility. Maybe they appear healthy and are stable for the first couple of days of life, and you get a chance to do a screen. And then they get transferred. Something happens, they develop some condition, and before going home, they end up getting transferred to another facility. If the baby has passed screening at the first hospital, the second hospital is only required to rescreen if certain conditions are met, and these are conditions at which we might expect the condition to cause or contribute to a hearing loss. So if in that second hospital the baby has hyperbilirubinemia at levels that require an exchange transfusion, they receive ECMO, ototoxic meds, they develop a culture-positive sepsis, or they have a congenital torch infection which may produce a late-onset hearing loss. With any of those diagnoses, we do require that the receiving hospital conduct a rescreening exam. Again, these are minimum criteria. You are always allowed and able to exceed the rules. If you want to conduct a rescreening exam on every baby that's transferred to you, even if they passed in the first hospital, that's certainly acceptable and allowable. What's not specifically mentioned in our rules is that if they were screened at that first hospital and did not pass, we would expect the receiving hospital to attempt to rescreen if you can prior to discharge, even though that's not specifically spelled out in the rules. But again, because of our other rules regarding transfers, the higher level facility remains accountable for ensuring that that baby receives follow-up testing. All right, this next section talks about personnel. And we do say in our rules that a licensed audiologist or physician shall oversee the newborn hearing screening program. And there's some items that they have to ensure that I'll go through. We would really prefer for hospital newborn hearing screening programs to always have the oversight of an audiologist, or at the very least collaboration with an audiologist, since their educational, clinical, and experiential background can be the most benefit with issues such as training other users on hearing screening equipment, troubleshooting equipment, and communicating information to families about hearing screening results and risk indicators for hearing loss. Excuse me, I've been talking for a while now. My voice is running dry. So about half of hospitals in New Jersey that have maternity services don't have audiology services. So for that reason, we understand that hospitals may not have the ability to partner with an audiologist, and we're left with the need to allow program oversight by a physician as an option in our regulations. Now, that said, it's also allowable and acceptable for the audiologist or the physician with oversight of the program to delegate the day-to-day implementation to other staff. Indeed, one model that we've seen and found to be very effective is where a hospital has one staff nurse take on management of newborn hearing screening as a clinical ladder project, or whatever you call that in your individual institution. But basically what we found to be the most successful is when a single and very committed individual takes ownership of newborn hearing screening. If that person is a particularly detail-oriented person, it's even better. The EHDI program has also asked that each hospital identify one administrative point person for the EHDI program. This is someone that we'll put on our email distribution list for updates, the ones that say, oh, your policies are due this month, or we have an interesting webinar coming up, those sorts of exchanges. So this can either be the audiologist or the physician with program oversight according to your policy, or again, it can be another staff person. It's the person who's going to receive any phone calls or emails from our program when there's a question about a screening result for an individual baby. It's going to be the person who gets contacted when we're trying to schedule our annual conference calls with hospitals. And also the person that we contact with any questions about hearing results that were submitted through the birth certificate system. So it should be somebody who is readily accessible to our Department of Health team and has access to both broad and individual baby level information about your newborn hearing screening program. So the person designated in your policy as having oversight of the program has several responsibilities and accountabilities. One of those is the oversight of the training and supervision of the individual screeners, the ensuring that results are recorded accurately and appropriately, ensuring that results of newborn hearing screening is reported to the state via the electronic birth certificate, identifying what education and counseling of parents will be conducted, and developing strategies to communicate the results to parents and to physicians. Also, this person is responsible for coordinating the activities of follow-up services and referrals for babies that need additional testing. And this person is expected to complete an annual policy and procedure review and make sure your policy maintains compliance with our recommendations. Individual screeners really can be any type of staff person that the hospital has decided to use. It can be nurses, it can be aides, it can be volunteers, as long as those screeners are under the direction or supervision of the audiologist or physician. And also all screeners should undergo an annual competency evaluation. That includes an annual review of their screening procedure, their documentation procedures, and infection control practices. For ensuring that your screeners are appropriately trained, we strongly recommend the National Hearing Screening Training Curriculum that is on the NJAC website, which is infanthearing.org. This little program now is online. A DVD version of the program is also available and was the first thing they came out with. Now it's actually on the website where you can just click through and watch it and sit down at the computer. And a recent update to the NJAC training curriculum is that they do have the availability to provide continuing education hours from the American Academy of Audiology and from the National Association of Pediatric Nurse Practitioners. In order to get those CEUs, users have to sign in and set up an account and complete a post-test and do some extra work other than just watching the curriculum. In addition, in our rules we specify what needs to be part of that training. Some of this is covered in the NJAC curriculum, but some of it may be specific to your hospital. So the initial training has to include performance of the screening, which is kind of obvious, but also to cover infection control practices, the general care and handling of the newborn, how to swaddle and calm that baby and keep them in a restful state so that you can get a good, clean test result. Your training needs to include where and how the results are documented, and also your training should include a discussion of the maintenance of confidentiality of the data. Section 1.6 of our rules addresses that screening results as well as demographics about mom and baby and risk indicators for late onset hearing loss have to be reported to the Department of Health via the electronic birth certificate system within 1 week of discharge or transfer. Currently, the statewide average for the time from discharge to submission of the hearing screening data via the electronic birth certificate is about 9 days, meaning that most hospitals are not quite consistently meeting this requirement for timely submission of results. If your time to data submission regularly or excessively exceeds this 1 week requirement in the regulation, we will take action. We'll start by notifying the EHDI hospital contact to see if you can improve the timeliness, but we have had cases where we've taken it to the hospital CEO, and in extreme cases we would consider notifying the hospital licensure program, because it is important for us at the Department of Health to know what happened to those babies inpatient and know their screening results. This screenshot here is from the current EBC system in use in 2013. It's our old DOS-based system. We will be beginning to go to a new web-based vital information platform that will include the electronic birth record beginning in 2014, and the requirement to report within 1 week of discharge is not affected because it's still our electronic birth registration system. So whether it's the old system or the new system, you still have that requirement to get the data in and get it submitted to us. We mentioned having quality assurance activities as part of your protocol earlier. One suggestion I have is that one QA activity you could do is a periodic audit or review comparing the data that was entered for a sample of children, comparing what was entered in the EBC or the Vital Information Platform to the actual results that are documented in your chart. There is an allowance in the regulation for refusals. The text in our rules is the same as the text in our law that address the exemption, notifying that the parents can refuse for bona fide religious tenets and practices. We aren't going to ask you to have parents provide documentation of their religious practices in order to comply with this. However, you are required to obtain or at least attempt to attain a signed refusal. The refusal also needs to be documented in the relevant field in the birth certificate system. I also want to point out that we have had cases where parents have refused screening during the inpatient stay, but they weren't refusing hearing screening per se, such as a family that wants to use a specific external provider either due to an insurance issue or just a personal provider preference. Or we've had a case where there was the family's belief system required keeping the infant's environment quiet for a period of time. And so they were willing to do hearing screening on the baby, but they just didn't want to do it in the first couple weeks of life. So in any case where there's a parent refusal, what we ask is that you assess and document basically both inpatient and outpatient refusal. So you document, if you're refusing to have the baby screened in the hospital, you can document that. You can document as refused, but then you also want to document separately if they are refusing to also have it done during their outpatient life of the child. And that concludes Part 1 of our EHDI 101 for our hospital EHDI contacts. Part 2 will continue with the regulatory responsibilities. We left off at Section 1.7, so we'll pick up at a Section 1.8. And Part 2 will mostly be focusing on follow-up and ensuring that babies after discharge receive the appropriate follow-up testing. Again, I would like to encourage that if you have questions that came up as you were listening to this presentation, that you please jot them down and you send them off to us, and we will be happy to answer those questions. And I encourage you to listen to part 2 of this webinar series, and you'll be hearing my voice again soon. Thank you, and have a good day.